Welcome everyone. For November or Movember Men's Health Awareness Month, we bring to you how COVID-19 has changed the landscape of male infertility evaluation and treatment. I am Sarah Ramaya, Curriculum Design Strategist and Webinar Coordinator at ASRM. Before we begin, please note, this webinar was developed by the Society for Male Reproduction and Urology and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. Please note, all attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question and answer window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. However, our panelists want this webinar to be engaging and interactive, so you are encouraged to introduce yourself in the chat window and raise your hand if you would like to comment or contribute to this discussion. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I'm honored to invite our moderator for today's webinar, Dr. Stan Honig. Dr. Honig is Professor of Urology and Director, Men's Health at Yale School of Medicine. He is immediate past president of the Society for Male Reproduction and Urology, current chair of the Reproductive and Sexual Health Committee for the Urology Care Foundation, and past president of the Society for the Study of Male Reproduction. Dr. Honig, over to you.
Thanks, Sarah. And I'd like to thank the ASRM for allowing us to do this webinar. I think it's going to be valuable both in person and also to be archived for not only the SMRU members, but the members of ASRM at large. The goal today is to talk about how COVID-19 has changed the landscape of the male infertility evaluation and treatment. These are my disclosures. The only ones that may be related to this would be Fellow, which is a company that has a mail-in Semen Analysis, and Posterity Health, which is a telehealth medicine company. We have two distinguished guests that will be speaking today. Our first guest will be speaker will be James Smith. He's Director of Male Reproductive Health and the Professor of Urology at University of California at San Francisco. Jim gave a similar talk at ASRM on the role of telehealth, and I thought it was so good that I thought he would share some of his thoughts on this as well. Taking the side to talk about how the changes during the COVID-19 program have changed, but maybe have not changed it for necessarily the better, is Ajay Nangia. He is the professor of urology and the vice chair of urology at University of Kansas Medical Center. So I'm going to just briefly present a couple of cases and then pass over the microphone to Jim Smith to give his talk, and will be followed by Ajay. So here's a case. I have a 50-year-old male who presents with Azuspermia initially for a telehealth visit. His wife is 36, has regular periods, and her workup is negative. There's no associated erectile dysfunction or ejaculatory dysfunction, and most of his history is negative. He is a smoker. He does drink relatively heavily, and he does smoke marijuana daily. So one of the questions we're asking, what are your next steps here after you review the history? And I'll just mention here that this is some of the things that you might see. You might see ordinary testicular ultrasound that looks at varicoceles, hormone testing, genetic testing, and semen analysis. And I'll go over this in a little bit more detail when we go over the cases. And in a follow-up to a telehealth visit, Do you do a face-to-face visit? Do you do a repeat video visit? And if it's a face-to-face, if the findings show a varicocele, don't, et cetera, how does it kind of change? What do you do? What do you do next? Do you use diagrams or videos to help you in your telehealth visits? These are the things that people like Jim Smith and others around the country are using on a regular basis to extend the value of the telehealth visits. The second case is a little different. It's a 38-year-old male who presents with primary infertility, who's referred with an abnormal home sperm test and then is referred to you. So do you prefer to do a video visit for this patient or a face-to-face visit, and why? Is it a first visit or a second visit? And how do you feel about home tests versus mail-in tests versus standard semen analysis? The rest of the history involves an initial evaluation where the wife is 34 and no other significant past medical history. So the second visit, is your second visit a video visit or a face-to-face visit, and why? So these are the kind of things that will show up in our history. And I'll pass this over to now Jim Smith, who will talk a little bit about the positive things that have come out of the COVID-19 crisis in terms of male reproductive health.
Great. Well, Stan, thank you so much for giving me the opportunity to speak today and to share our experiences at UCSF with everyone. So let's see, there we go. So these are the disclosures I have for fellow posterity and inherent biosciences. So, what do these patients have in common? I mean, some of the same kind of questions that Dr. Honig was just raising. Do these patients, how do you handle these patients? And, I would argue, and these are all patients who I see routinely. These are all patients where you can do telemedicine visits, whether managing a patient with low testosterone seeks fertility and you're giving him clomiphene, patients with azospermia, transgender patients, erectile dysfunction patients, fertility preservation patients, are all patients who can be managed effectively through Zoom, through telehealth. So thinking more broadly, what are some of the barriers that our patients face in terms of being able to come talk to reproductive urologists? What are the barriers that we face? A few years ago, Dr. Nangia, Dr. Mehta, and Dr. Dupree and I wrote a manuscript that was in Fertility and Sterility, where we laid out a number of these barriers, and there are many, whether from education, income, cultural barriers, knowledge about options, geographic barriers that have been published in other work by Dr. Nangia, and much of the financial strain that often insurance doesn't cover the kind of care that we provide very well. So how do you handle this? How do you handle when people have to take time off of work to come and see you? So how can we break down these barriers? Well, what does it really mean when we're trying to evaluate patients? Well, we are trying to establish a relationship with people. And what's been strange about COVID is that when people are in our clinics, everybody's masked up and goggled up. And it's sort of a bizarre turn of events where sometimes I feel closer to husband and wives or partners when I'm talking to them virtually. Even they may be in separate rooms separate virtual rooms while I'm talking to them. Physical exam. How do we handle this? How critical is it for us? Getting a couple of semen analyses, getting your lab testing. Well, as I grappled with this and thought about it, and I think about from a testicular exam standpoint, the physical exam is better for testicular size and consistency. I mean, you can get the testicular size and volume from an ultrasound, but it doesn't seem quite as satisfying to really give you the same sense of what's going on. I'd say this is important, but not critical. What about the vas and the epididymis? The physical exam is really far and away the best way to get this information. And I would argue that for our suspected obstructive patients, this is really important. But for many of the others, that's not as important. Tumors. I think that both modalities do well for this. And this is key information. And what about the clinically relevant varicocele? Physical exam is probably better here in terms of helping us figure out on whom we should operate. When I put this criterion here in this chart, skillful practitioner widely available, you're really thinking about someone like us, a reproductive urologist, someone who's done a lot of physical exams, knows what they're looking for. There are not that many reproductive urologists around the country. There are more places to do ultrasounds. Whether those are truly high quality ultrasounds, there's probably some debate to be had there, but it is easier to get an ultrasound than it is to find one of us. Well, as I said, the testicular size probably equivalent. Your vas and epididymis most relevant, FSH less than 8. I think really figuring out the varicocele, the exam is key. But what about the cost of coming to the clinic for the exam versus the cost of the ultrasound? What's covered by insurance? What's not? Should you examine everybody and the feasibility of this? Could you utilize highly trained physician extenders? Our recommendations are from the ASRM. Our guidelines advise that we should not recommend varicocelectomy for patients with non-palpable varicoceles that's detected only by imaging. Well, what about a semen analysis? Well, so how do we deal with this? Well, you could send your patients to a local lab. That for us, this has been one way to get it done. There have been issues with accessibility, insurance coverage, but more often it's a problem of inexperienced staff and just getting pretty substandard semen analysis quality. Quest or LabCorp. This used to be a better option, but at least in the Bay Area, there have been few Quest and LabCorps that remain available. There was one very far away from the Bay Area where you had to bring a sample within 30 minutes, and it became quite difficult to get it done this way. Send to a fertility center. This gets you a high quality semen analysis. It becomes more of a scheduling issue where my team would have to be involved in the scheduling of the semen analysis. There's often long transport times to actually get to the lab. Sometimes it's expensive. The cost can be prohibitive if people are paying out of pocket. What about the mail-in approach? The mail-in approach, it's far more comfortable. You don't have to take time off. The costs are probably lower if you have to pay out of your own pocket. A con would be that, generally speaking, these are pay out of your own pocket tests. Many of the tests that are done by a patient at home are done by them at home, with one exception that does have a CLIA certified lab. To tackle some of these challenges, we looked at this and worked to develop a system that would allow us to mail in semen samples. And we published our work this year in Fertility and Sterility. Essentially, we ran a prospective cohort study of men in the Bay Area. I went through extensive research and development to develop a kit that was a box, a temperature sensor, and media, as well as a gel to stabilize the temperature of the sample. And did many semen analyses to test this. Ultimately, the sample was produced at home. A bicycle messenger brought it into the lab within 1 hour, and then repeatedly that sample was tested in this in varying temperature over time. And overall, there were about 2,300 semen analyses that were performed. In the actual validation portion of the work, there's about 104 samples. And what you can see is that rather than seeing a precipitous decline in motility, using this system, we saw motilities that began at around 60%, and over the course of hours, all the way out to about 52 hours, the motility declined linearly. And on average, it declined by about 0.4% per hour. And looking at this graph in the bottom left, you can see that patients out of these 104 samples, there was no precipitous decline in any of these patients over 52 hours. And so we looked to see how well the measured and predicted lined up with what was actually observed at the baseline initial semen analysis. And the correlation was very, very strong in these data. So shifting gears to what happened at COVID time. So essentially, there have been about 650,000 visits at UCSF by video this year. Over 600 providers now doing them and 100 different kinds of practices. The goal has been to make video visit a really seamless part of the experience for patients and improve patient and staff satisfaction. And looking at this chart, this looks pretty impressive. In the time leading up to COVID time, it looked like, boy, video visits were really, really ramping up. And then when you see what happened at COVID, all of that increase was really just a drop in the bucket to what happened once COVID happen. And there was just widespread adoption across UCSF. And within our own clinic, essentially the paradigm that we embraced was this idea of flipping the clinic and flipping the model around for all of us. What happened is that our clinic, with the narrow hallway and lots of rooms on either side, it never felt safe, with everybody having masks and having 100, 120 patients who were moving through, getting vital signs, checking in, going over their history, getting into rooms, and it was just too much. Nobody felt safe. So instead, we shifted to most everybody being video visits, and then mostly it was procedures at the clinic. From a staff and patient standpoint, this was a really positive experience for them. Essentially what happens from a practical standpoint is it just flips around the utilization of staff. So before, we'd have medical assistants who'd be getting vital signs, rooming patients, checking on pharmacies and medication lists to go into Epic. What happened now is that the medical assistant calls the patient ahead of time. Hey, you have a visit today, and troubleshoots any problems, and then is just there as time goes by. Also rooming other patients who are in clinic. From my perspective, I log in as a host. I see patients in the waiting room. I bring them in. I bring in partners. I bring in translators. And we can have all of them in the same room in the background. I have a medical scribe. That person sits in the background as well. And after the visit is done, then I ask my administrative staff to do the things that they need to do for surgery scheduling or whatever we need to do. We found that Press-Ganey scores have consistently been higher than they were in person. Reimbursement was also in line with what we had seen previously. It just changed the demand. Now I have multiple days video visit, and I have one very busy procedural day and another operative day. But it has, if anything, my volume has increased over time. In the beginning, we had a number of late cancellations and problems, but having a medical assistant call helped a bunch. The interpreter and getting the interpreter online was also a challenge initially, and we had to work through those to be able to have an interpreter readily available. And some of the challenges from a physician's standpoint is just having a comfortable workspace. Crouching over your laptop with the laptop camera in your face is kind of terrible. And trying to use the little tiny mouse pad, but having a comfortable workspace can make it pretty fantastic. Also, being able to add in videos or up-to-date research is really handy and much more difficult. I was typically handing out flyers in my clinic to try to accomplish this. What about the relationship building with patients? And I know Dr. Nangia is going to talk about this. I've generally found this a pretty positive experience, talking to patients and been able to form good relationships with people. And there are always some people where this just doesn't work, and we bring them into the clinic. We've been able to increase access to patients without utilizing this precious exam space. We're able to expand to do more procedures than we used to be able to do. Providers have been happier by not having to commute quite as far, and a lot of patients have been happier. Many of our patients are coming from far away Northern California, as far east as Nevada, and this has been a positive experience for patients in that way. It has been a little bit confusing though in the beginning, and we had bugs in the system as we worked things out. And physical exam is really important for some patients. When you look at my own practice, we found that on average, we're able to add a few extra patients per half-day clinic session. And we found that there were significant savings for patients when we did a pilot study of looking at these results. And then specifically in the 18 months leading up to the pandemic time, we saw about 2,300 patients, and about 27% of them were video. And this flipped completely when we went to video, where now about 17% of my visits are in person, and the vast majority of these in-person visits are either for physical exams or procedures. And so from a volume standpoint, my volume increased significantly over this period of time. From a charge and collection standpoint, generated about 5,400 RVUs during that time and $1 million in collections. And so far, and this is ongoing, rolling collections, but about 6,300 RVUs and 1.2 million in collections. So it doesn't seem to be worse from that standpoint. For me, the things that have been really critical is hiring a scribe and having scribe. These are virtual. I have scribes now. They're all over the place. My main scribe is in Austin, others in Chicago, and they're all over the place. And they're with me by video in the background. And I find that enormously valuable. Having just a comfortable workspace, a strong internet connection. If you have that kind of choppy, crackly internet connection, that is really is terrible. And there was actually a time where internet went out at my house and I had to go over to Whole Foods and sit in front of Whole Foods in their parking lot until my battery ran out on my laptop and I had to cancel clinic because I couldn't find anywhere else to go. So there's some sort of different challenges that I would not have expected before. Having a good microphone where you don't have to deal with the ambient noise. And then these staff training. I mean, it's a different model to make it work well. And in the beginning, it didn't work well, and there were lots of no-shows. Patients are starting to figure it out, and this becomes a part of their experience. And I generally had a pretty positive feedback, with, of course, some exceptions. It's much better to do this in blocks of time rather than trying to mix this in person and then calling people. It just takes 10 minutes or something to get your telemedicine space up and running. And if you're running in between procedure and going to call somebody and get them, it doesn't work well. It's just stressful and everybody's late and mad. So in summary, I have found that telemedicine is very practical for andrology practice and really for most of our urological specialties, from cancer to stones to women's health. We found that expands access to patients. I see patients in their office wearing hard hats, walking around their job sites, working up on their roof, in their backyard, just all over the place. And that I really think that's terrific. It can be an efficient utilization of our time and can increase volume. At least for us, the revenue has been very similar between the two approaches. The no-shows and really working this out just requires training the staff to a new model of doing this. And I'm optimistic that the benefits of telemedicine are going to outweigh some of the challenges that certainly exist that we need to continue to work through. So thank you very much. And I'll turn it over to Dr. Nangia, my esteemed colleague and friend and professor at the University of Kansas.
That just proves my point. I'm an old fart and forgot to unmute. So there you go. That's the problem with Zoom. No, so I have an opportunity to reflect from the days when we had paper charts, dictation, to electronic medical records, and now, of course, video conferencing, telephone conferencing, my chart, the ways that patients communicate directly to us, especially if you have Epic. And I think the important thing before I go on is just to remind, I have no actual financial disclosures despite some of the positions I hold in leadership. But this is very important right here. This is the white paper written on telemedicine, and look at the date. It was originally written before COVID. It's like watching that movie Contagion before COVID happened, right? You kind of predicted the future, and then it happened. Very thoughtful members of our panel, and they really, if you ever get a chance to read a very thorough aspect of how telemedicine, not just communicating with patients, but education, surgery, et cetera, et cetera. It's a very thorough description, and I've given the link down there. It is, easily accessible and free. But interestingly enough, telemedicine started quite some time ago, partly restricted by technology, as you can imagine. We didn't have Star Trek back in 1999. We were still very clunky with the internet and with video conferencing. But as you can imagine, although this was neurology and stroke, monitoring the stroke patient, figuring out if it was embolic or hemorrhagic, you can understand that the early adopters of this didn't really require a physical exam. Psychiatry, psychology, but then as we know, necessity is the mother of invention. As the technology improved, our abilities to do more than humanly possible starts becoming the norm. And then we have smartphones. Zoom of course, made a killing out of COVID. because they adapted their video conferencing. Now there's Microsoft Teams, et cetera, et cetera. Wi-Fi getting quicker and quicker. We're now at 5G on our phones. The memory capacity of our phones are larger than our computers we had not long ago. And so technology clearly has defined some of our abilities. And interesting, they did an evaluation of our 2020 census in AUA and found, as you can imagine, that telemedicine had to, out of necessity, increase. And I think it's important at this juncture just to make sure we understand what we're talking about. Are we talking about during COVID or post-COVID? Well, this is obviously post-COVID. What has COVID taught us? We had no choice during COVID. Either you adapt or you die, right? We all know what that very first 3 months of virtually hospitals almost went broke when they had to shut down virtually everything. And we adapted with early versions of Zoom, early versions of FaceTime. I know friends and colleagues who just use their personal Apple accounts to FaceTime their patients to just survive. But what lessons did COVID teach us? First of all, again, necessity is the mother of invention. We have fussed and fussed and fussed with getting reimbursement for phone calls and then, of course, video conferencing. And only because of this COVID crisis did it get accepted by Medicare and private insurances, and hopefully continues and lasts post-COVID. I like to compare this to what would happen if the oil ran out. Well, then electric cars would go absolutely berserk, or nuclear cars or Back to the Future cars, right? We would do it out of absolute necessity. We would not be wasting our time with $3, $5, $10 gallons. You wouldn't be, we might be, Mad Max or Waterworld and killing each other for gas and water. But the needless point is that necessity is the mother of invention, and we literally waited on the legislative side for this change to happen. So as you can see, necessity meant we had to feast or famine, and we all adapted to using telemedicine while we couldn't see patients. As you can see in the third bullet, 50% of urologists provide now, as of 2020 and moving forward, very much like what Jim was talking about, telemedicine encounters for new patients, and 77% for established patients. And that is the essence of my practice. Actually, no, I take that back. I always now post-COVID, during COVID, we had no choice. I didn't do a physical exam. I just did it to sort of get, some billing and actually patient service and accessibility. But now I've gone back to certainly seeing my patients, new patients, face-to-face, but largely because of the physical exam, a very respectful one-on-one interaction, and then try to make everything after that telemedicine. We do my chart, we communicate our results back, we don't obviously bill for those sometimes. If you want more than 3 sentences, in my opinion, on electronic communication, then I'm sorry, then you need a telehealth. I'm not going to type my way through, and therefore it is a billable event, maybe plus minus on some of that phone calling or communications through my chart, which is the method that Epic talks about. So, I think it's a matter of starting with, of course, physical exam and the whole history taking, and then let it the whole bit with you don't need anything beyond that, and you really are communicating lab results, etc. Then that doesn't require a visit, which I totally agree with. So here it is. Urologists primarily receive compensation for video visits, and actually now more so telephone calls, which again, we're not lawyers. I don't know how they could bill. They were fee for service. We were restricted by insurances and Medicare. Now we can bill better telephone calls. And this is just in the space, literally, of a year, if that. So as I just said, I am very much a holistic person. I like to think of myself as a human. I am a physician, and as such, I find it my duty to serve the community in a face-to-face environment, the healing hands, if you will, of doctoring. It doesn't require it all the time. It doesn't require it all the time. As I've said, these are the two things. Basic vitals, yes, if you know how to take your vitals at home, wonderful. They've got EKG monitors now you can do at home, wonderful. But if they can be done properly, physical exam, right? I just want to stress this. There is no scrotal ultrasound, CT or MRI, that is really going to do as good a job as a basic physical genital exam. The vas deferens, the fullness of an epididymis, the issue of a subclinical varicocele versus a clinical varicocele. 30% of ultrasounds are false positive for the finding of a varicocele. You know, testicular size, yes, is ideally better on ultrasound than it is on a physical comparison with an orchiometer. Yes, true. Can you tell epididymal fullness like we do maybe post-vasectomy? No, you really can't tell that on an ultrasound. CT and MRI are great for maybe prostate and ejaculatory duct issues, but really, they have to remember one important point. They may not be seeing you in a teleconference at their initial one, but they have gone somewhere else to get an ultrasound, CT, or an MRI. So someone has physically seen them, if you will, and you just didn't do a physical exam, and you've done the telemedicine visit. You know, ultrasound, CT, and MRI are not, repeat, not surrogates, alternative surrogates for a physical exam. The days of a true old school physical exam, like we learned years and years ago, you know, feeling the liver, feeling the spleen, looking for hernias. Nowadays, God knows, I don't know, general surgeons almost don't need to, they just do a CAT scan, right? You can almost make some more important diagnosis. We can diagnose a lot more quickly, if you will, in those situations. But for the genital exam, by far the Jim highlighted that in a very nice table, you know, testicular masses to whatever. And we need, ultimately, that's why I'm going to stick to my guns on this when it comes to why a visit is required, okay? And again, the important part here is, okay, let's just say we want to save those people time and you do the imaging locally. Again, some human being has had to put the probe on someone's scrotum and do the CT scan. And let's just say we also say, well, don't come in to see me, but did your primary care physician do a physical exam since you know, just maybe recently seen them? Well, we all know primary care physicians, when it comes to the genital exams, are notoriously bad. In fact, there was a study done that showed that 30 to 35% of primary care physicians missed testicular masses, palpable testicular masses. So if you need to do a, I wouldn't call it a specialized, just a complete and thorough and experienced genital exam, there's nobody better than a urologist, general if it be, and even more so a subspecialist like an infertility specialist who is literally spending all day focusing on thickness of a vas, thickness of an epididymis, the presence or not of a true clinical varicocele, which is a very subjective finding, as we know. So I just want to point out, I'm stressing the physical exam for a reason. Now, here's the other part of this, okay? I believe that we are holistic. I struggled during COVID with social distancing because I like to shake people's hands. I like to feel the firmness of that commitment in a handshake. Old school, call it what you will, but it is really an important transmission of warmth and sincerity. And you can't do that over, you can express it vocally, I know you can, and we do often. They can feel the, you know, the sincerity in a teleconference. But definitely after COVID, during COVID, no question, everyone was paranoid about touching anything and fomites and touching your nose, touching anything and dying, right? And now we've got the vaccine, whatever. We're post-COVID, the contact has started, I still Purell, going in, going out, right? Universal health precautions shouldn't change. Maybe the mask is the last one that's to go. All right, hugs. All right, I'm sorry, if a woman and a man are crying, like when you've given them a bad diagnosis and you've been empathetic, there's something still to be said with true sincerity and compassion. And you can't always do that without that. We do that with our families. What difference does it make if it's for someone who's suffering? I find that very, very important. And I used to say in the early days of COVID that it was just physical distancing. That's all what we were doing. And that videoing is perfect. We're still communicating with our family and friends. We're communicating with our patients. But that little bit of real social distancing without contact, maybe I'm just a touchy-feely guy, but that's fine. That's who we are as a species. We are a social species. So I think social distancing was probably the right context. Not seeing your grandmother, not seeing your mother, not seeing your friend who's sick down the road. That is stressful. And right, I agree. First visit, make that respectful connection, do the eye to eye, and then move on either through MyChart or through video conferencing or telephoning. Absolutely. Now, Jim talked about access to care and how it's improved and stuff like that. And I agree. Nobody wants to drive in to a visit, sit around, wait, park, sit in the waiting room, be told to walk in, doctor's late. And I agree with Jim. If you're going to do telemedicine, do it all in one go. Don't mix and match, because you can't keep on time. If you're going to make someone wait in clinic, think about what it's like making someone wait online, in their car, in their office, walking around. They're like, damn, I've got to get on with the rest of my day, just like they do when they come to a doctor's visit in person. So I think if you're going to do telehealth like I do for follow-ups, be respectful and get them started on time, so that you're not bouncing around between procedures, clinic, patients. It is too stressful, and we have enough burnout in medicine. But however, not everybody has easy and accessible internet. That's what the Obama administration was trying to do, was increase broadband in the rural areas. There is huge, and yes, Kansas is a rural area, so there's no doubt I have a little, emphasis on that. There are areas with very much half of a state which is which is rural, and so not everybody has a smartphone, and no, not everybody has. Literally, I didn't have computer literacy a minute ago when I didn't unmute myself. All right, just goes to prove a point. All right, and we are lucky that the people we see in reproduction are generally younger and more savvy. All right, but here's the point. What do we know about reproduction in our world? And Jim's right, we've published on this. Being looked after for infertility is generally an urban, higher socioeconomic class, usually white, insurance, and educated with good insurance. And, not everywhere is San Francisco. That was a little jab, but not really. It's true. We do have an access to care, snobbery, bias, and we aren't accessing the right people anyway. I hope that, as Jim has said, as maybe more people are able to get these tools. I mean, getting a computer, especially a laptop with a camera, isn't cheap unless you happen to get it through school or work, or now the cost of computers are going down, et cetera, et cetera. We all know what the cost of having a home Wi-Fi is. It can be up to $50 to $70 a month. Some people can't put food on the table right now, okay? And so I'm not trying to be a socialist or an English socialist, but I'm just trying to point out that it exists. And this study in 2019, really using the 2019 data, stresses this, okay? You can't beat these numbers from the American Community Survey, right? 105,000 people that were evaluated. 33%, if you will, without a desktop or laptop computer with high-speed internet. 20% were without smartphones or data plans for wireless internet connection. And 14%, so there it is. There's the data, there's the evidence, and this isn't something I made up clearly from my previous slide. This is the evidence, all right? Non-metropolitan households were significantly more likely to be deficient than metropolitan. That's really no surprise. Again, this disparity in race and ethnicity are very stark here as well, okay? When compared with households with private health insurance, no surprise, yet another one. They were more likely to have been non-insured and no public insurance coverage and be lacking computer access. And so again, higher incomes, more family members living at home, distributing the cost of a Wi-Fi maybe through adult members of a household. But again, there's no difference again with these other forms, which was not only computer access, but Wi-Fi, et cetera, with the abbreviations I apologize for. But again, this was just published, okay? So, and this actually now is from Jim Dupree's work, a really wonderful co-partner in all of this, another urologist out of Michigan, and he looked at his data like Jim did. And clearly, what do you find? Reproductive patients are younger. and most of them spoke English and mostly white, just like what I told you about the access to care to infertility that we right now deal with. All right, and 68% were white collar workers. So again, that just highlights the disparity in our own world without telemedicine. So why see patients even? Just call them and have a whole consult on the phone. Well, we've had the phone since Graham Bell, right? So why couldn't we? We couldn't bill for it. We could document it, sure, we could write all this stuff down, but we couldn't bill for it. So as I've said, necessity is the mother of invention. Insurance companies and Medicare, Medicaid have started paying, they're less restrictive, and that's made the hugest of difference. As you saw from Jim's data, you can still bill and survive now. You're not just giving free care. Now, what's interesting is the state-by-state variability of the rules. Okay, we are not licensed beyond our own state or two. So what does that mean from a legal malpractice stability protection? And psychology's done it for years, and they have 20 plus states that they are all cross-licensed in, with rules that each state agrees on that they need to have achieved, going to an accredited program, this certification, that certification. And actually, I discovered from the AUA telemedicine white paper that for medicine, that actually exists in 28 states too. So Jim, as he's saying, he sees people from Nevada. Got to be careful. Do we have the cross licensing to see people in Nevada? I do. I have a Missouri license and I have a Kansas license, so I can see anybody in both states clearly. But Nebraska's not far away. Oklahoma's not far away. I see patients from all of those. So why is it that I can see a patient in my clinic from Oklahoma and not be worried about malpractice, whereas doing a teleconference with a state that we're not licensed in makes me liable? Those rules have to be adapted. They haven't, but there are 28 states that are collaborating to do that. But like I said, you bring them to your home base, you're protected. You don't, you are liable. And so that has to change to be consistent so that we're not liable, period. And like I said, you can do telephone conferences. Like sometimes when Zoom doesn't work, I call the patient, I'm like, I feel like a fraud right now, but I'm sorry, I was going to do it on Zoom, your phone doesn't work, your whatever doesn't work, you're in a tunnel, whatever. You dropped your, as Jim told you, you drop your Wi-Fi, you feel like you're in like Kansas all of a sudden, right? All of a sudden you're in like rural Kansas. All of a sudden you're looking for a signal at your local grocery store, okay? That's not normal. So we are humans. We like to see people. We have to know what facial expressions. We are like chimpanzees, and we do communicate through frowns and other kind of verbal communications. Telephone is a telephone, but now we can bill for telephone, which is at least better. We cannot bill for my chart messages, which is interesting, or maybe you can add them together and bill for an established visit through communications online. But we are humans and we need facial recognition. What about security of the call and the video? Jim pointed out, what if your signal's lost, right? I mean, you're right. We've seen people sitting in their living room. We've seen people in their cars. I've seen people in their bikinis. I've seen people with the husband in the front and the woman's naked in the background in the bed. Like, have some respect. At least try to dress up before the visit, but needless to say, I've had cats, I've had dogs. I've looked at people's paintings on the walls. I've seen their kitchens, great interior designing, ideas many times, but the reality is the security of Zoom. We all know this. When Zoom first came out, people just came in and what did they do? What's the right word I'm looking for? But photo bombed or video bombed, and kind of got into meetings and hacked into them. And we all know that even in a more realistic, like just even medical records, Mayo is dealing with an employee who hacked into 1,600 executive medical records, and now there's a class action lawsuit. So security of the web, security of the your own database is forever being hacked. If it's not target database, it's this or that. So why is videoing any different, right? Why is face-to-face better? Well, face-to-face better, unless you've got a camera in the room, is confined to the room, right? It is. It's a better environment for HIPAA unless you end up seeing somebody you know in the hallway or in the waiting room. But needless to say, cybersecurity is probably what I should have got into instead of medicine. Now I think about it, I would have been probably a lot younger and retiring in San Francisco by now. But anyway, so the point is that we've got to still rely on the security. We know the internet is not as secure. People sitting in their cars, etc., when they're taking on these visits, and they're very, very sensitive. So this is the sensible practice and compromise. This is really what I have to say, because this is what I think is good about this discussion. I still believe very strongly, like I said at the beginning, new patients should be seen in person. You need to do the physical exam. You develop an instant, it doesn't have to be a deep relationship, but you've developed some rapport, at least now post-COVID, with human contact. Physical exam, without a doubt, there is no substitute to a GU exam. Follow-ups, I agree. I hate having to go in and tell people about a lab result, testosterone, whatever, on Clomid, and feel like I'm such a fraud dragging these poor people in. There is no need. But then again, these people do have to go get their blood work. So they are having social interaction to get their blood work, pre-Clomid evaluation, which has gone into the electronic record. So something has to be met. People do have to meet. They may not meet with you, but they've gone in to see somebody to do something that did something. And the home semen analysis that Jim talked about, obviously there's no way I can touch that. That's the future. And I think it would be great to save people, especially in rural areas, to be able to send it in. If we can deal with degradation on motility and volume and concentration. So home testing is here to stay. I think that's innovation that we are able to proceed. We can do genetics tests now, 23andMe, but just a saliva swab. We should be able to do a karyotype equally that way. And so I think that convenience is without a doubt excellent. But I do believe, again, like I said, and if someone wants to write 5,000 sentences in a MyChart message, I'm like, honey child, I cannot respond to this. I am not going to write 10 pages back. This is not an essay. You either have a telehealth or you come in, and I'm fine with either. But follow up where I don't need to do much more than conversation, like psychiatry, like psychology, I think it's prudent that there's no reason why you can't see them on telemedicine in a fixed. And so I've always felt with our children, with social media, and looking at these goggle boxes, cell phones, flat screens, we're going to end up devolving to have one eye. We don't need binocular vision very soon. A pair of palms with a thumb so we can tap on our keyboard. And we're going to have Wi-Fi routers on our foreheads and in our heads. So thank you so much for your time. I'm Old Fart, and back over to Stan.
Well, thanks, both of you. I think you've both given kind of passionate views as to the good, the bad, and the ugly of telemedicine. I think a couple things. Number one, in addition to this, there was a nice presentation at ASRM. If some of you are interested, for those of you that registered, Jim Smith, along with Jim Dupree and Tolu Bakari, gave a nice hour similar talk on telemedicine. Jim Dupree talked a little bit about access to care, and Dr. Bakari talked a little bit about diversity and inclusion and equity in terms of what Dr. Nangia spoke about earlier. I think in the last couple of minutes, I just wanted to present these cases and get the opinions of Ajay and Jim. One thing I'll mention, Ajay mentioned that there isn't a home blood test. There actually is a home blood test that is available where you can actually prick your finger and put it on some paper and mail it in. And it seems to correlate pretty good with serum testing. I think Jim might have some more information about that. But that's a test that will probably be something that can be available clinically, and it's available for hormone testing at the present time. So I'll just go to this case again. The first case was a 50-year-old azospermic man who presented for a telehealth visit. And I'll say to Jim and Ajay, what would your next steps after you review the history be? Would you order a scrotal ultrasound? Would you bring the patient in for a physical exam? I know AJ is going to bring him in for an exam, but Jim, how do you feel about this?
Well, this is the kind of patient, a lot of it depends contextually, and I'm still really trying to work out the best system for patients. If this patient lived a long way away, this patient for me would get labs and would get an ultrasound and would get a semen analysis. If I'm not sure what data you have already, but a repeat semen analysis or two. But this is having information like this would be fairly typical for somebody who lived far away. When I see a varicocele, in this case, because he's azospermic, I would talk to him about the low chance that repairing a varicocele would actually have in improving his azospermia. I'd probably get a second semen analysis here. I mean, likely this patient's because of the testicular atrophy and slightly elevated FSH, he probably has non-obstructive azospermia. So we're probably on the path of microtesy. On the flip side, he has many historical factors that could potentially be impairing spermatogenesis. And a lot of that I can talk to through telemedicine and show him slides about spermatogenesis and the benefits of cutting down on drinking and marijuana and improving his health.
Let's say this patient was, let's say, mildly oligo, maybe 5 million, 40% motility, where a varicocele repair might be valuable. I mean, I think that the question is, if you get this scrotal ultrasound, are we ordering too many scrotal ultrasounds? Then we have to bring them in anyway to differentiate between a subclinical and a clinical varicocele. I don't know how you feel about doing the scrotal ultrasound in that patient. Do you bring them in for a varicocele repair without examining them and examine them the day of, like we do for a vasectomy and a physical exam before we do a vasectomy? Ajay, Jim, what do you think about that?
So if I could say, of course I'm going to say physical exam first, but let me just be devil's advocate for a second. Let's just say that following Jim's principle of, let's say we need to do the initial visit as a telemedicine. Okay, so you set a protocol. This person needed to do, let's call it a home semen analysis. He does a home hormonal evaluation because again, let's say, I don't know, someone had to have done the test to show that he was azospermic, right? And you do the confirmatory one by having him do it home. You do a home kit for FSH and a testosterone, let's say, which testosterone home kit. I don't know about how good that is, but let's just say you get that. You get that, okay, normal volume, azospermia, FSH 10. That's not the CBAVD guy, right? If the pH is normal as well, which I don't know if you can do that with a home kit. But this would have been a non-obstructive picture right now, just from looking at his lab tests and semen analysis, okay? And then you could do a home karyotype swab or a Y-chrome testing too. So you're leaning this towards the guy. And so the question, Stan, is does he need a physical exam, or you just send him and you get a scrotal ultrasound, there's atrophy of the testicles. The question of a varicocele, and then, or whatever this is, a subclinical or not, begets the question is, do you fix a varicocele anyway in azospermia, which may be non-obstructing, right? And that would be yes, probably, except in a subclinical situation. I wouldn't do it in a subclinical. And that's when I would say, all right, if I'm going to make a surgical decision, then I'm going to do something very cutting edge by doing a varicocele surgery in an azospermic patients in the hopes of cryptosospermia or oligo or something, or making microtesy better. Then I want to examine this patient to make sure I'm doing the surgery for the right reason. But otherwise, I could have made the diagnosis of non-obstructive spermia, sure, I think, on the testing that you may have done prior to the tele visit. So sometimes we get that, right, from other urologists or REIs. They've done everything for you, and you go, okay, I'm going to tell you that there's no sperm production. We just have to do microtesting, and we have to do Y-chrome testing. So I can respect that. But if this had been a guy with a normal FSH and normal testicular size, and maybe then you find out there's low volume and it's acid pH, and you need to do an exam to prove there's CBAVD? Yeah. Or beaded? Yeah, I do. actually, or do a MRI to look for ejaculatory duct obstruction. Yeah, I mean, but the guy who has a normal FSH, normal testicular size, let's say on a scrotal ultrasound, that you might say, obstructive, don't know. Well, maybe, you know, do I need to do a full exam? Maybe that's just to prove there's VAS, because that's the only thing that doesn't show up well on ultrasound, probably. Okay, that one, you know, so I do believe in the physical exam, especially for varicoceles, especially for people and their VAS.
If I can interrupt for a minute, you know, Jim brought up the point about what is a more skillful exam? Is it a physical exam by a non-reproductive urologist or an ultrasound? And I think there's incredible variability with the ultrasonographers as well. They may not be familiar with measuring veins. They may not do it in the standing position. They may not do it with Valsalva. So I think that Jim's kind of table that looks at like a skillful practitioner versus a scrotal ultrasound, I think you really have to know who's doing the ultrasound and who's doing the physical exam to really make a logical decision as to what's a more valuable test. I don't know if you have any other thoughts there, Jim.
You know, I think that's an outstanding point. You know, and as I've tried to grapple with the best way to provide care to patients, the things that I've leaned upon are, I have a nurse practitioner who's essentially my extra set of hands, and he's been extensively trained, and he's physically there helping in lots of ways, both in the hospital and then seeing patients. And so the days that I'm not physically there to do the exams that need to be done, like in the context that you raised, I mean, a patient who I'm thinking about surgery, I'm going to do an exam, or my nurse practitioner is going to do an exam. So that's been very, very helpful to expand the pool of qualified people here. The second is that on my ultrasound report, when I'm ordering that, as I say, please do this in supine and standing. I'm looking for a varicocele. Please look for that and give me a volumetric evaluation of the testis. So I wasn't putting that in the ultrasound order before, and now I do that. And so I've been getting better quality reports.
Sarah, do we have, can we extend this a couple more minutes, or are we on a tight 1 hour time frame here?
We can extend to about 5 to 7 minutes.
Okay, so just a couple of other questions along the lines of what Ajay was saying in terms of talking to patients. You know, when you have to share difficult information with patients, and I think that at least for me, the telehealth visit, I mean, that physical touch is really important. And I know the IVF people, they have to share, you know, negative pregnancy information over the phone. But, you know, when you get a Klinefelter's diagnosis, I mean, a lot of the times we know it ahead of time, but you get like a balanced translocation, or you get a uncommon AZF A, B, and C microdeletion. How do you feel about bringing a patient in versus doing it on the phone? Do you feel like in this day and age, you can do that, Jim, over the phone, or AJ, what do you think about that? I know how you feel, but.
You know, I'll answer first if that's okay. But yeah, I mean, just today, I gave a man, his fiance who was, you know, had permission, diagnosis of Klinefelter, which I had already met with them in person because he had non-obstructive Azuspermia. And I already put, unfortunately, the hammer in the coffin, so to speak, because I had to tell him that this wasn't obstructive and this wasn't just a biopsy, and it was a microtesty and IVF ICSI. And I had to do that twice on Wednesday in person. And it, you know how devastating that is. But to say the information of what the testing showed, Y-chrome, karyotype, I try my best to do it on the phone. I don't feel strongly. I mean, it's like saying to someone, can you give them a cancer diagnosis over the phone? Two schools of thought. You tell them, and then you bring them in to have the conversation once the dust settles and the shock factor wears off. Or do you tell them in person, they don't hear the rest of what you say, and they go home and say, what did he say? I just heard cancer. So, you know, so in that regard, I tell them on the phone, they digest it, and then I'm happy to telehealth with them and go into all the details of the next step. Nowadays, I don't have a problem telling them on the phone. I don't like it. I do like to know where they are when I tell them the information. Are you in your car, driving, flying, you know, whatever you're doing? Are you sitting in an airport? I mean, it's not the best time to communicate. Of course, we don't know that unless we're visually seeing them. You know, like any time calling someone on the phone with bad news, it's never, you have to know where they're at.
Well, I suppose from my perspective, it hasn't been, you know, that doom and gloom to present this information. I mean, if you think about, you know, I see many cancer patients who don't have sperm, many many non-obstructive Azuspermia, whether Klinefelters or Kalmans or any of these. And I find it from an educational standpoint and a communicating concepts to people, I actually have found it more satisfying and feel like I can educate patients better when I can put a video or put my PowerPoint slides up and say, this is what's going on the inside. And, you know, these are your three options. We could adopt or donor sperm IUI or do a microtessie. This is what a microtessie would mean. It's a X% chance of success. And I found that to not be a terribly difficult conversation or any more difficult than it would be in person.
And I would disagree with that. I mean, the reason why, you know, people hide behind social media is because they don't have to face somebody. You know, in your situation, it's different, Jim, because they know your name. You know, we can't hide anonymously behind what we say and do.
I see them. I mean, we see each other.
No. I get that. But it seems just so much more abstract. And the world has changed, meaning people have got used to doing things on TV and communicating on FaceTime. And so it's not as, you know, not as old school needed anymore, as you said. You're right. There is definitely an aspect of it. I just feel that, and this is a bad analogy, and I'm really sorry. You know, it's one thing to play at war and point guns at each other. It's another thing to face the man or woman against you who you're going to shoot. Okay? There's a different palatable degree of connectivity that you hide behind your white coat, one thing. It's another thing to hide now behind a TV screen. And I don't know. That's me. That's old school. I respect what you're saying. You can communicate through your images that you have that you can share with them, which is very helpful, whether it be in person and especially in, I don't know, I can understand. And like I said, I do it with follow-up visits. I just often would like, just like I said, with new patients, to have had a human face-to-face and then be done. I mean, if they can't do it, they can't do it. And once in a while, I'll do new patients. Absolutely. You have to be respectful for distance. Absolutely.
Jim, I'd just like to close with the following. Jim, I don't know if you have one kind of pearl. You know, I know that we've spoken to other people that share diagrams. Do you have a PowerPoint, like a 3 or 4 slide thing that you kind of go through the hypothalamic pituitary axis? Do you show the anatomy? What are the kind of 1 or 2 pearls that you could share with the group here that you use on telehealth that you think are valuable as we close up this session?
It's an expanding slide deck. It's not 2 or 3, it's more like 70. I mean, it's from penile prosthesis and having a video about an IPP. And this is what it means when you're putting in an IPP. And this is how a guy works it, to this is what spermatogenesis, or in the case of my pediatric patients, this is how we'd actually do an injection of cells and showing the retrograde flow of fluid, to this is what a semen analysis distribution looks like. This is what you're, so, you know, just each patient, I'll curate the list and I'll say, okay, I'm going to show you a couple of slides. And then I will, it may be
you'll pick and choose from your deck as to what's valuable for that particular visit.
70 slides or something that keeps getting bigger. Like, oh, I didn't explain that question very well. I'm going to build that up a little better. And I'll show 2 or 3 for, and you know, it's whatever the patient needs.
Great. All right, well, I'd like to thank both Dr. Nangia and Smith for their great presentations and their ad hoc passion for both sides of things. I think this is an evolving thing. And, you know, it's interesting how we'll have to see how this evolves over time. I think we kind of peaked at telehealth in our institution, and now we've kind of dropped down doing a lot more face-to-face again, whereas Dr. Smith does still 70% of his stuff telehealth. So thanks again for participating, and these slides will be available online, and the presentation will be online on the ASRM website. So thanks again for joining us.
Thank you, Dr. Honig, for moderating such a fantastic discussion. To our panelists, very exciting, interesting conversation. This session was recorded and will be available on our website. For any further questions or comments, please contact us at webinars@asrm.org. This concludes the webinar.